Okay, thank you very much to come back. And as you know, we have here a motto, a theme, innovation jumps in implantology. And I try the last 9 years my students to motivate that they rethink their protocol, their cooking book. And this is the best situation if something goes wrong or is a little bit slow, a little bit complex, to simplify it, to fasten it up or whatever. So be creative, and then you can perhaps a little bit improve your clinical workflow. We have already heard from Michael. And now I'm very happy that two guys coming from Australia, and one is 5 years ago, graduated in 2013 in October. He's here, Misak Habibi. He comes from Perth, right? And yeah, I like him because we have a lot of discussions, really high-end level discussions, and he has already a lecture here in another MOI Congress presenting his master thesis, but he's moving on. And he's together, I think, is your master student, yeah, David. So he's now a tutor of the MOI program and perhaps a lecturer also in future. And they present now both their creative way on All-on-4. You're familiar with All-on-4 is a brand name, but it means 4 implants placed in the dental's jaw and immediately restored, mostly with a fixed restoration. And they add on something, and I'm very happy to have the next 45 minutes with these two guys. The stage is on you. Thank you for coming.
Thank you, Paul. It's good to be back. It's a little bit nostalgic walking along the river. I didn't know if I'd feel like I belong, but I still feel it. So thanks for the invite. Oh, there's us. So this is a view of my beautiful city, Perth. And I actually live in South Perth, which is just this side of the river. So the view from our apartment is very similar to this, and I get to go walking along here quite often. We're presenting here this idea of an upgrade to the All-on-4 concept. Upgrade, perhaps, if Professor Muller heard the word, he may cringe in his in his mansions. But I believe that it is an upgrade, and we'll present that to you and see if it's something that you would find useful for your clinical practice. This study is a collaboration, as Paul mentioned, with David, who's just finishing the MOI at the moment. And I'll go through the methodology of this concept that we've been doing at my practice for the last few years. And then David will show you the results of our retrospective study. I have a lot of slides, and if you excuse me, I'm going to be quite quick with how I go through them. I'm not going to try to talk about all of the literature behind this concept in the past. But basically, we know that when we have terminal dentitions with advanced dental disease, or when we have edentulosum, it can often present a challenge for reconstruction. In particular, when we talk about immediate reconstruction, which is where a lot of patients are going these days. In order to create the foundation for implants in a terminal dentition with a history of periodontal and endodontic infections or long-standing edentulosum, we often would need to look at bone augmentations, nerve transpositions, sinus elevations, and so on. Now, all of these, of course, have their morbidities and their complications, as well as the length of time that they add to the process for patients. In particular, it's the concept of the delays that patients are not happy with. And as you know, the idea of the All-on-4 was to be able to address these patients and give them an immediate prosthesis, even in cases of limited and compromised jawbone. So the idea is that it's a graftless solution. Even if we're missing bone, the idea is that we're not rebuilding bone, we're working on the limited bony foundation in the mandible between the foramina and in the maxilla, in the premaxilla, and potentially expanding onto posterior anchorage in the zygomas or the pterygoid. We found that the literature, this concept over the last 15 years has really shown that the outcomes are successful, they're predictable, and they're comparable to other types of implant reconstructions. And those that are well familiar with the All-on-4 concept and practice it regularly and are aware of the refinements and the details of it understand that it's a lot more than 4 implants It really is about a whole methodology and a design of restoration that allows it to be predictable in the long term. So a lot of the criticisms that we hear about the all-on-4 concept have, I feel, are unfounded because they're based on mistakes in the all-on-4 protocol rather than the all-on-4 protocol itself. Primary stability, we all know, is a crucial concept for immediate loading, and obviously when we're dealing with just 4 implants in a jaw, it becomes even more crucial. Cross-arch splinting is the reason why this concept is successful, because it really diminishes the strains that the bone, the abutments, and the implants experience compared to standard implants, standard immediate implants. In the concept of all-on-4, or what I'll be discussing today being all-on-4 plus, we can also add additional supplementary implants when we feel it's appropriate to augment the overall primary stability for a case, if it's lacking in other implants, or if the requirements of that patient, if they're a bruxa or history of excessive wear and tear, you might feel is wise to incorporate additional implants. So one main concept of the all-on-4 is, of course, the 2 axillary anterior implants and the 2 angled posterior implants that go at an angle over the mental foramina or under the maxillary sinuses with the idea of extending our anteroposterior spread. So even though we have lack of bone availability or thickness or height in the posterior segments, we're trying to extend from an anterior anchorage point as distally as possible for the concept of increasing our anteroposterior spread. Now, this, of course, increases the distance between our implants, which can have advantages for vascularity, for hygiene, and so on. It reduces the need for augmentation and increases implant lengths. So the bone-to-implant surface of integration can sometimes be higher on a 4-implant all-on-4 than a higher number of implants positioned vertically. So this concept that we need more anchorage is often misunderstood because we may be achieving more anchorage with the all-on-4 concept. Finite element analysis shows that by angulating the distal implant, we actually reduce the strain on the framework, on the implant, and then therefore on the surrounding bone. Won't go too much into that, but this is a very important concept because it really indicates that the distal angulation is not a poor second cousin to the idea of axially positioned implants, but the idea of it is to actually improve the biomechanics of the full arch restoration. In doing so, by angulating the distal implant, we can reduce the fatigue on the distal implants in particular, the componentry of the distal implant, the screws and the abutments, as well as potentially, by reducing the strains on that area, reduce the possibilities of veneering material delamination as well in the restoration. Traditionally, the all-on-4 was done with the Nobel Speedy implant by Professor Malo, and in more recent years, in particular with the development of the Nobel Active implant and studies by Babush, it has really taken a foray into narrow implant situations in even more limited areas of bone, with comparable outcomes to the traditional all-on-4. So this shows you the idea of the all-on-4, where we're working with angled implants at the back, we're increasing our anteroposterior spread, our bone-to-implant contact. We are using angled abutments, in particular in the posterior segments, to give us a common path of insertion for the final restoration. And very importantly, one requirement of the all-on-4 concept is sufficient alveolectomy to create sufficient restorative space. And we'll go through that as I show you a couple of cases as we go through. Now, in cases where even with that concept we can't address the needs for immediate reconstruction, we can still, in many of these cases, avoid bone augmentation by the use of zygomatic implants. This is just a little drawing of the kinds of immediate all-on-4 reconstruction that we can undertake depending on the presenting bone availability. So the implants in the anterior segment can also be angled if required. We can go into the tuberosity, the pyramidal process, or even the pterygoid bone for plate, for anchorage of distal implants. We can go to the zygomas. Traditionally, the all-on-4 zygoma will have a couple of implants in the premaxilla and a couple of zygomatic implants, and then, of course, in severely atrophic cases, the quad zygoma. I'm just going to show you first the concept of a traditional all-on-4, because an all-on-4 traditionally involves a provisional restoration with the use of acrylic on titanium cylinders on multi-unit abutments. And the point of this methodology that we're presenting today and the subsequent study is to show you that we can now bypass the idea of a provisional restoration. But we'll go through how this works. So this patient came in, she has a history of cleft lip and palate, basically no maxilla and severe periodontitis. Little bone availability. I'll be skipping through all these pretty quickly. And according to the all-on-4 principle, we have flattening of the ridge, good alveolectomy to give us an even restorative space along the whole arch. We expose the mental nerves. We angle the distal implants over them in order to make sure that they're placed in a safe position whilst giving us maximum anteroposterior spread. The primary stability is of utmost importance. And in my practice, believe it or not, we generally aim for up to 60 or 70 Newton centimeters on appropriately designed implants for this purpose. Of course, not all implants are suitable for that. Use of often straight multi-unit abutments in the anterior segment and angled multi-unit abutments in the back segment. Now, in this case, we basically had like a denture setup that we inserted at surgery, relined, and took a bite in terms of assessing the final restoration which she was having, which is an upper denture and a lower provisional restoration. We finished the lower provisional restoration as a denture and then did a direct pickup, so no impression of the implants was even necessary, and was able to, the following day, sorry, it says surgery there, that's incorrect, restore it with these prostheses. Now, these are provisional restorations. Usually in a provisional restoration in the all-on-4, you wouldn't have these distal segments behind these lines because the framework cannot withstand reliably that area without fracturing. But because of her low forces and her upper denture and the plenteous restorative space, we decided to incorporate that. And this shows you how an all-on-4 normally would look after restoration. You've got your titanium cylinders, your multi-unit abutments, your implants, and your distal angles over the mental foramina. Okay, so basically looking at where we see the mental foramen, it's around that point that we start to angle forward and work with that safety zone whilst increasing our anteroposterior spread. So that's historically one of the ways to make a provisional all-on-4 restoration. Now, provisional all-on-4 restorations or provisional restorations of any sort have their complexities, and the most common of these is adhesive and cohesive fractures of denture teeth, and more dangerously, I guess, acrylic denture-based fractures. Screw loosening and screw fractures are also not uncommon. And the more unsupported a distal cantilever is, as our speaker Michael alluded to earlier, the more likely that cantilever would be under strain. So technically the provisional all-on-4 restoration should have no cantilevers. This is an example of cohesive fracture of denture teeth on an all-on-4 restoration. And the idea is that many studies indicate that to minimize these biological and mechanical complications, our provisional restorations need to either be thicker, have some sort of reinforcement, and have no distal cantilevers. So the idea of the plenteous restorative space becomes even more crucial. Holzkohl looked at categorizing the ideas of implant-based fractures on all-on-4 provisional restorations. Class 1 was just tooth fractures, and then anterior segment fractures were of the acrylic bridge were considered class 2, class 3 in the distal segment, and class 4 segments that don't collaborate with any of those. And what you'll see with the results of the study that we'll present today, these three in the blue, we basically can eliminate with the idea of immediate permanent restorations. This is an idea of this is an example of a PMMA framework that developed a transverse fracture, which is a class 2 fracture there. And the patient I had many years ago done, I think, some sinus elevation, probably too high according to our last speaker there, that these implants were placed. And there was no bone in the premaxilla, well, insufficient bone. At that time, I was not an all-on-4 practitioner, and we made him a locator denture. Years later, he went to Singapore and added way too many implants in this section, and basically came back with a provisional PMA bridge that was fracturing due to his lateral excursive forces on that area. Now, we converted this to a titanium acrylic hybrid, which is able to now withstand those forces, and we can completely eliminate the possibility of a class 2 or 3 fracture in this prosthesis. But it was difficult to do with all of the different sort of implant types, implant level and abutment level combined restoration. This was corrected, by the way. That's why we take x-rays to find problems like that. But the idea is we want to do this now from the outset. Why go through the other process? Okay. I'll skip through this one. All right. So most studies show that we need to do something to make these all-on-4 restorations stronger, especially if we want them to last longer. But what I propose is, why have them at all? Okay. Are we prescribing provisional restorations based on just convention, operative, and lab ease? Can we really get by without cantilevers when patients want to have these as a functional outcome, sometimes for longer periods than what we would like? And the complications of potential fractures of these acrylic bases, can they be only dangerous for our implant integration, for crestal bone loss and implant failures by removing our cross-arch splinting? Are the perceived benefits of a provisional restoration real, or do they outweigh the disadvantages? A lot of the requirements that people put into the idea of a provisional restoration involve the idea of tissue remodeling and the idea of aesthetic assessment. These are very valid, but I'll show you in our methodology we try to look after these in the original concept. The idea of immediate permanent restorations has been done before. It's the Novum framework by Brannemark was the first to do that. It has a lot of fatigue and difficulty issues. I've had to repair a couple of these and they're not much fun. There's also, of course, Digidi's concept of the intraoral welding of frameworks, which is a huge step forward in the idea of immediate restorations. I would say probably changing them from provisional to semi-permanent-ish. Okay. And now the trefoil concept being touted by Nobel Biocare, where it's an upgrade on the Novum framework. However, it is able to withstand, around 0.4 millimeters this way and that way, horizontal, vertical, and transverse compensation for, variations of implant placement after the guided surgery. Now, the idea of this concept and what the reps that keep calling my office would like me to think is that this is better now because you don't have to use 4 implants, so patients don't have to spend as much. You can help more patients. But when I look at the methodology and the complexity of what's involved here, and the fact that it's really only for edentulous mandibles, and usually, the study done so far for it is also against upper dentures, it can only go so far. And the methodology which we're about to present really achieves this and more, in my thinking, a lot easier. So what we're wanting to achieve is the idea of a permanent titanium milling on the implants within 3 to 4 days of surgery. Just to mention where this idea comes from, obviously the all-on-4 concept builds on Professor Malo's concept. My colleague Dr. Fibishenko in Australia innovated the concept of the all-on-4 plus, which shows some of the methodology that I show you today, and then I've incorporated the idea of the immediate titanium framework. That's just to wake you up. Do you like my office? It's a recent renovation. I'm quite happy with it. All right, so I'm not going to go through these because I want to show you a lot of pictures, but the inclusion criteria for this study and this methodology is quite extensive. There's really not much that this methodology cannot be useful for, but by all means come and ask myself or David about the idea of exclusion and inclusion criteria. The one important thing for all patients is a 3-month soft diet protocol that we prescribe. Our planning, of these 189 arches that are in this study, some are digital, some are analog, and some are a combination. Okay, I try to do whatever I've got time for to do the planning quickest in the most effective way for the case before us on that's coming up. And I don't think there's a right or wrong, but certainly having digital and analog capacity at your disposal and having a lab that's experienced with both can allow you to deal with the tricky bits of any particular case. So in this case, we wanted to design the incisal edge position based on full face digital design, but I'm not showing you the full face photos because we have a lot of slides to go through. But to show you that the idea is, we need alveolectomy to create room for these restorations in the first place. But when we have extensive gingival display or vertical maxillary excess, we often need more extensive alveolectomy and alveoplasty to position the teeth where we want. So this is that same gentleman, just to show you sort of the design work that went ahead preoperatively. Okay. We also may choose to do 3D virtual planning. This case that I'm about to show you that David's also presented in his thesis, I did this for the purpose of presentation. Most of the cases in the 189 arches here do not involve 3D Simplant planning, and they're really on the concept of assessing the bone based on 3D imaging and modifying the plan as required by the sort of nuances of density and any defects and infections that might be in the jaw to allow the concept of immediate restoration to take place. So that's we're planning on him an upper all-on-4 plus titanium and a lower locator denture. Just to show you many cases that are terminal dentitions, we're dealing with simultaneous infections that need to be dealt with at the same time. Just a quick video going through the arch from one side to the next to show you the sort of defects and infections in the bone that we might be dealing with and planning our implants around. And you can see the crestal position of those implants in relation to the level of alveoplasty that we will need. This is that patient, and basically this is his preoperative design work, where we want his new smile line to be, some of the basic instructions that I give to the lab. I've learned to give the most important instructions and not too many. Okay, the simpler and the more crucial those instructions, the more likely that they're followed precisely. We may have digital or analog casts. In this case, it's analog casts, duplicate models where the teeth are removed. On the models, we never do the alveoplasty unless it's absolutely necessary to fit the teeth, because I like the lab not to guess the alveoplasty that I will do. I can work with more space, but not enough. But if they do too much, it might alter what we need to do in surgery. So we're going with the all-on-4 protocol with these particular variations. We can incorporate narrow platforms, additional implants, posterior anchorage, and we can use different implant designs, not necessarily only the all-on-4 brand, as long as they are suited for this idea of high primary stability and reliable and well-designed multi-unit abutments. Now this is that same case. We spend a long time doing extensive curettage and bone refreshing in areas that might be infected. The implants are placed in their final positions. We can use our guide that we've made from a preoperative design to check the alignment of our multi-unit abutment angles and modify them if required, and close over the tissue. In this case, it required a bit of repair grafting for the buccal dehiscence that was there, a fenestration that was there. It doesn't often require that. And really important to take, for me, to take x-rays of the impression copings when we move on to the next stage, because that's where all of your good work can come undone with one poor impression. Okay, lower implants were placed for locators for denture. One important aspect here is that we create a flat restorative profile on the tissue with our alveolectomy and our tissue manipulation, and we pinch it down, compress it down with the healing caps. We then take a full arch splinted restoration by splinting a stainless steel wire to these with a hard dimensionally stable material, and we use triad gel from Dentsply for this purpose. You'll see in our impression there are points where it meets the tissue, and that's by design. Because we have compressed the tissue down, when you have put healing these multi-unit abutments, these impression copings on here, that's no longer compressed on the tissue. So because we want to compress the tissue for our final restorative profile, we will push it down with an instrument and cure some resin there, which you can see here, so that we do not create a concavity in our final restoration. Crucial to this process is the indexation stent. So this is a printed or analog clear denture, basically, that does not have labial flanges, but very importantly has a full palatal and tuberosity coverage, because, as previous speaker mentioned, that's our point of reference and stability following the alveolectomy. We place titanium cylinders or PEEK abutments on the anterior implants and relate those to the stent. Now, in this case, the alveolectomy was quite extensive, and the way it sat, I misjudged it as a little bit of a cant that you can see right now, even in that process. So this is where the photographic records are also quite important, to be able to convey that to the laboratory. Okay, so what we do is take extraoral photographs to align the midline with the patient's face. I've zoomed it in here so you can't appreciate his face very well, but it's always important to capture the whole face in that. So we can give the lab some instructions in terms of the angulation of the teeth, any cant, curve of Spey, positioning, midline, and so on. That is then taken to the lab and is scanned. Won't go through the machinery and everything that's involved here, because I'm sure I'm already starting to take David's time. But the idea is to scan, even though we've provided analog impression, we now want to scan the analog impression, or the model of the analog impression, and scan the indexation stent and relate those together. Following that, we're able to actually design a titanium framework that will support the tooth setup that we have designed. Now, it's important that we have a robust bar design. We've got sufficient distal extension. We want full cantilevers in these cases. And we need to bear in mind our restorative profile. So technically, we shouldn't have many cases where there's undulations in the bar design. It should always look flat, because that is an indication that we've had enough alveolectomy and that we're able to have a high enough restorative profile to minimize our complications. Restorative space, my apologies. Finally, the milling is completed according to that particular design, and teeth are then overlaid over that for the try-in. Okay, we won't go through the steps of that. David's covered them very well in his thesis. So there it is, the master cast being poured with a gingival mask. The MMR with the indexation stent, scanning of that model with implant bodies, and relating that to the setup that we want in terms of a titanium design. There's the titanium bars milled and the teeth overlaid, ready for try-in. So this is the next day. We keep the areas where screw access is passing without a tooth over it, because if we then change the midline, move the position of these teeth, we don't want to have unnecessary holes in these teeth that we're expanding. And we've got a denture setup that we're going to use at the try-in. So we use our photographs to really give the lab very detailed information about the things that we want to change and relate that to the indexation that they're carrying out. And in this case, this was the patient's first try-in. Now, at the first try-in, we may not have as much tissue compression present as we will for the final restoration. If you look at this restorative profile, you'll see it'll be altered by the final. Have a chat with the patient, do some phonetic testing, and have a good assessment of the vertical dimension, the phonetic space, which if you've increased your vertical dimension too excessively, that's often the first thing that sticks out at you. And we're able to give those instructions to the lab for the changes that we want to make. For this patient, we did a second try-in, and again, going through some of the same tests. He's got a lopsided lip, but obviously we're not going to design to that. And he's got a mobile lower denture at the moment. I found he needs a bit more phonetic space on his S sounds, so we're changing the arch form and the vertical dimension to deal with that a little bit. But he was doing quite well considering the lower is just a loose denture at the moment. And that's the following day when we inserted the teeth. Now you'll see a much fuller sort of aesthetic profile, and really importantly, you see that there are no flanges, there are no concavities. What we're doing with this restorative profile is compressing that tissue, which we've already reduced, and we've pulled the palatal tissue over the crest, and now we're compressing it so we can design the tissue in a hygienic fashion. And a few months later, pick up locator of the lowers. Okay, and that's his final outcome there. So we placed 2 implants in the tuberosity areas. This one was too low in primary stability, and considering the fact that we have a removable appliance in the lower, we felt it would be unnecessary to wait for that to integrate. We went ahead and restored this as it was. Okay, so a crucial part of this is a soft tissue contour. For me, that's the hallmark of successful All-on-4 treatment. More than anything, if I want to check if it's a good outcome, I want to see this. I don't even need to see the patient, because this should generally be very tall. It should be well hidden away from the smile line of the patient. It should have a flat, compressive, restorative margin for hygiene and tissue guidance. Okay? So we all know the bone sets the tone, the tissue is the issue. My friend Alex says the space makes the case. Okay? And a big part of the benefits of the All-on-4 reconstruction is the aesthetic tissue replacement that we're able to achieve for a lot of these terminal patients who otherwise have very unsightly restorative profiles. Okay? Just to show you the rolling over of palatal tissue over the alveolectomy, so we have a thicker, more keratinized zone that we're compressing in our final reconstruction. Okay. And one telltale of the sufficient restorative profile and height is the excessive space from our implants to the incisal edges that we would have achieved. Okay. The case I just showed you is for this patient here. And again, if we look at her bridge from another angle, you can see the very smooth and compressive restorative profile that when it goes in the mouth just compresses that anterior tissue and is hygienic for flossing if even required. Okay, that's her outcome. So you can see it was very important to hide this restorative margin for aesthetic purposes as well. Even when we have implants that are in the way to achieve this outcome, if we can't remove them, we'll section them so that it doesn't interfere with the design that we're actually wanting to achieve rather than what the patient may already have. So just a couple of examples to show you where alveolectomy needs to be a bit more extensive. Okay, so in this study we looked at the anterior implant positions, the posterior as the standard positions. Okay, sometimes we added an extra midline, and sometimes there was a distal implant, in particular in the maxilla. Cantilevers were categorized in this study, and you can see when there is insufficient cantilever, what we had in this case is there was actually tooth in this section, and it broke off, and we this was a fault of the technician. If anything, we should always extend these. We can always cut them back after the try-in. We looked at 4 categories of cantilever based on the number of teeth hanging. Okay, class 0, class 1, class 1B when there's 1.5 teeth, and class 2 when there's 2 teeth cantilever. Okay, how are we going for time? Because I need to get on to David. Okay, I'm going to skip the cases that I was going to show you and let David get on with showing you the outcomes of our study. This is just to show you, however, we can do this in a digital design as well, like Michael showed before. This is also using Trios and 3Shape to achieve the same thing in a digital manner. The same process. Try-in, framework, and insert. So you can see with this type of tissue manipulation, alveolectomy, even a couple of days after surgery, we always have a very clean and flat, not a raw looking, not an inflamed and irregular looking tissue. And in fact, it's going to look better when the bridge is on there and compresses it a little bit.
So first of all, it's been a pleasure to actually do this master thesis under Misak's guidance. When initially we were presented with this idea, it kind of blew me away, being a slightly younger clinician who hasn't had much experience with these type of restorations. Essentially, the aim of the study was to retrospectively analyze the results, the complications, and the successes of mandibular and maxillary restorations restored with the all-on-4 plus type protocol. And Misak's gone through extensively of the methodology, so I'll just touch base on what we actually investigated in the study. Our implant survival and failure criteria was a modification to Albrechtson's criteria, which a surviving implant was classified as one with the absence of pain, mobility, swelling, and infection. It had been restored with an all-on-4 plus tie restoration, and it remained stable throughout the follow-up period and did not require removal at all. A failed implant was an implant that required removal or could not meet any of the success or survival criteria mentioned previously. From a prosthetic standpoint, a surviving restoration was an all-on-4 plus tie restoration that remained functionally stable throughout the follow-up period. And a failed restoration was one that required removal. And often the removal of these restorations that failed was secondary to biologic failure of the implants. The mechanical complications we investigated were denture tooth fracture. This was the most common complication that we saw. Prosthesis-based fracture, which Misak touched on briefly, which related mainly to cantilever extension. Prosthetic screw loosening. Prosthetic screw fracture. This type of complication was most common in patients with a history of bruxism, and that was found only in a couple of cases. Relining or recontouring of the definitive prosthesis was required. When I was presented with this idea by Misak, my first question was, what about the soft tissue? How can you go straight to a final restoration when the soft tissue is just unpredictable? It can resorb over time. And resetting of teeth. Biologically, we looked at any implant that required the treatment or the management of peri-implantitis, or any implant that was no longer incorporated into an all-on-4 plus tie restoration. Within the study, we had 135 patients enrolled, 72 men and 63 women, which were all consecutively treated with all-on-4 plus tie restorations from May 2014, I think it was, up until April of 2018. The mean age was 56.5, and we had a mean follow-up period of 13.3 months. When we look at the follow-up, obviously some patients, when they come in for these types of restorations, they think they get the treatment, they do the 3-month follow-up, and that's it. So some patients were lost to follow-up at the 3-month mark, but I think it's a great number of patients have completed the 12-month follow-up, around 105, and we've got 58 patients who've completed the 2-year follow-up. The opposing dentition, I think this was something very important to record, as it does contribute to complications and failures. Majority, more than half of the restorations were opposing another fixed full arch implant restoration. We had around a quarter opposing a dentate patient, dentition or a partially dentate jaw. And the remainder were opposing a locator over denture or a removable denture. The distribution. 129 maxillary arches were restored with all-on-4 plus tie, and 60 mandibles, giving us a total of 189 cases included within the study. Misak mentioned cantilevers. This is a final restoration. Patients are expecting to have a full dentition. I think the World Health Organization classes a quality of life based on 10 teeth. So from molar to molar or premolar to premolar with a slight extension. Immediate and delayed loading. We had 13 cases that underwent a delayed loading protocol. Bear in mind, even though the loading protocol was delayed, the patient still received the final restoration without a period of provisionalization. This was a statistically significant difference between mandible and maxilla. Part of the reason was in double arch cases, the preference was always given to the maxilla to be restored, and a period of second stage for the lower. The number of implants. Misak mentioned we started off with a framework of the all-on-4. Some cases required additional implants. This was based on soft bone quality to augment total primary stability. So in a lot of cases, you'll find that a midline implant was placed. Anterior-posterior spread was sufficient. Sinus anatomy allowed for a good AP spread, but the stability just needed to be augmented by a midline implant, for example. Additional implants were added in the pterygoid or the zygoma if we had a limited anterior-posterior spread, and also the opposing dentition, as well as a history of bruxism. You notice that in the mandible, there was less cases that required additional implants, only 4 cases, 2 of which required midline implants and 2 of which required distal implants beyond the mental foramina. Most of the additional implants were placed in the maxilla, and around 30 cases were in the midline. This is a new slide. I haven't seen this one. Okay. Cantilever. When we look at the cases, out of the 189 cases, we had 70% with bilateral cantilever. So patients walked out with the final restorations with bilateral cantilevers, and only 20 cases did not have any cantilever extension. Part of the reason, I think, was because of maybe pterygoid implants were placed, so there was no cantilever necessary because the terminal implant was that far back that there was no extension beyond that. And if we look at it from a number of restorations, number of side, we had 378 sides. 15% had bilateral cantilevers, which were class 2, so more than 2 teeth, with the majority being around 1 tooth cantilever. The cumulative survival rate, 6 implants failed within the follow-up period, 4 maxillary implants and 2 distal mandibular implants, and both of these patients had these implants fail mainly due to not adhering to the soft diet protocol. The prosthetic survival rate was 98.9% within the follow-up period. And again, the 2 prostheses that failed were secondary to implant failure. Biological complications, 0.1%. In one case, a 1.5 implant was placed through an impacted canine position, so the primary stability on this implant was not great. An additional implant was placed in the 1.3 position. 31 months later, the patient was getting a little bit of mucositis around that implant, and the clinical judgment was then made to remove the abutment and bury the implant. It wasn't removed though. Complications, this is what everyone wants to see. 12.2% had prosthetic complications. These complications were mainly the denture tooth fractures. A couple of cases exhibited cantilever extension fractures. So when we look here, the tooth fractures was at 11. 11 out of the 23 prostheses had denture tooth fracture, mainly limited to the anterior area. 2 prosthesis-based fractures, and this was due to insufficiently supported cantilever. So even though there was a titanium framework, it did not extend far enough to support the 2 teeth that were extended. Once these cantilevers broke, a remilling was done to replace those 2 restorations at no cost for the patient. And if anything, it really stressed the importance of extending that titanium framework further back to support the distal cantilever. Screw loosening, 1 patient, a history of bruxism. He had multiple screw loosening episodes as well as a couple of screw fractures, and we modified the patient's recall protocol when we see this, as well as administration or making a new splint. Relining, 3 cases. So we question the soft tissue changes over time. Within the 189 cases, only 3 cases had a reline required, one of which was the one that had the implant buried. When you bury the implant, you need to reline the pros to compress the soft tissue of where it is after the implant and the MOI has been removed. The other two cases did require a reline because of some soft tissue contraction. I think Misak showed one of these photos, but here's a photo of some of the complications. Yeah. And a distal cantilever fracture. Shackleton's study actually mentions that any cantilever extending 15 millimeters is more likely to exhibit a cantilever fracture. Anything 15 or smaller, you're pretty much safe. We compared the study to previous immediate loading protocols that went to provisional as well as though that went to a final restoration. So when we compare to Marlowe's paper, Marlowe's research as well as Babush, they had a range of around 94% to around 98% implant success rate and a 93% to around 100% success rate from the pros point of view. We had a 99.3% implant and 98.9% prosthetic cumulative survival rate. Narrow diameter implants was an interesting one. Once the Noble Active implant was introduced, Babush then released a paper treating patients only with narrow diameter implants. Now the criteria for that was that 3 out of the 4 implants required would need to be a 3.5 millimeter diameter. The other implant, it didn't matter. In our study, we had 16 cases. Of these 16 cases, we had 100% implant survival and 100% prosthetic survival. Compared to Babush, very similar, 99.6 and 100%. Zygomatic implants, Marlowe's paper as well as Agliardi. We had 6 cases, I believe, Misak, which had at least one zygomatic implant. And of those 6 cases, 100% prosthetic survival and 100% implant survival. When we compared to protocols that went to an immediate final restoration, Brademark Novum, at a 5-year recall, there was an 87% success rate of the pros. So 13% of cases had complications or failures. The teeth in an hour concept, prefabricated surgical guide, prefabricated lab bar, it's all done in one visit, tissue punch, guided surgery, delivery of the final bar, lab process to then deliver the final restoration. Within their follow-up period, they claim to have no complications at all to implants or to the pros. Speedmaster system was more so in the mandible. 4 interforaminal implants were placed, fully guided with prefabricated bars, a very, very similar concept to the teeth in the owl. And obviously the GD's intraoral welding technique, he's got 6-year follow-ups now. Originally it was a provisional protocol, and then he went on to expand it to permanent restorations, and his paper in the maxilla and the mandible had 100% success prosthetically and implant-wise in both the maxilla and the mandible at 1 and 2 years respectively. Comparison of the prosthetic complications. When we compare the complication categories that we had with the other papers, is very, very similar, the type of complications that are occurring. Mostly denture tooth fractures, cantilever fractures. Again, 5.8% of our cases were acrylic tooth fractures, compared to the Marlowe papers around 27%, I believe. An interesting finding which we found was that 20 out of the 23 complications were all double arch cases. So cases that had an all-on-4 plus tie on the top and an all-on-4 plus tie on the bottom were more likely to exhibit acrylic tooth fractures, denser-based fractures, possibly due to lack of proprioception. But when we look at the research, 2015 by Marlowe, at the comparison of double arch versus single arch cases, there was a 16% failure rate in double arch versus 13% in single arch, which was deemed to be statistically significant. In another study by Marlowe, comparison of full arch ceramic, porcelain fused metal implant restorations, had twice the likelihood of ceramic failure when opposing another implant restoration. Cantilever extensions. So Drago's paper concluded that CAD-CAM titanium frameworks that supported denture bases and denture teeth with cantilever anterior-posterior ratios less than 1.0 had virtually non-existent complications. So it's important to take into consideration the cantilever extensions, as this will set you up for failure, particularly in the distal areas, which can more often than not lead to implant complications. How did we manage the complications? Sorry. Most of the complications were managed with occlusal adjustment. We also retightened the screws or replaced the screws more frequently for the patients that had a history of bruxism or were more susceptible to damaging the prosthetic componentry. and also an occlusal splint. In 19 cases, there was also a supplementary measure taken, which was the administration of Botox injections into the masseters shortly after restoration. Conclusion. Within the limitations of the study, I think that the All-on-4 Plus tie, aside from the minor repairable complications, holds its merits as a predictable solution for immediately rehabilitating patients without the need for a provisional prosthesis, which can often increase chairside time, as Michael very briefly touched on, with repairs and whatnot. Yeah. Rehabilitation of the completely edentulous patient. Based on the rate of the complications that we received in the 23, 20 of which were double arch cases. So maybe as a clinical relevance point of view, we can rehabilitate patients with a fixed all-on-tie prosthesis opposing a locator prosthesis, which is still a fixed removable option. Compliance to the surgical and prosthetic protocol, I think, is key. Misak spent a lot of time speaking about the alveolectomy, as well as having a very flat restorative platform and the prosthetic design. Significant alveolectomy provides us with increased restorative space. I think we determined the baseline for the anterior segment was around 15 millimeters and posteriorly was around 10 millimeters. Creating that flat platform allows compression of the soft tissue, which results in less chance of tissue gap formation underneath the pros. The incidence of the repairs were all repairable. Same day repairs by the lab, aside from the 2 cantilevers which required a remilling of the titanium framework. Limited follow-up. Patients have obviously disappeared when they've received their restoration, so I think more long-term data is required, and I think we're working on that, on recalling some of the patients that have disappeared. Just some acknowledgements. First of all, to Misa and his guidance into complete the master thesis. It was a long road, but we got there in the end. The MOI 15 family. We've got a group chat going. Everyone's motivating everyone to finish on time, to get there. We want to see everyone on stage, so that was definitely something that pushed. As well as family and friends and support staff back home in Sydney and Townsville. Thank you.
Very much. Very good. Thank you. So, thank you very much for this comprehensive lecture showing the protocol and the results on a lot of cases. Yeah, there are any question? We open the discussion. Here, there's one.
I have a question on the choice of material. The titanium frame, as far as I know, it's a lot less stronger than chrome cobalt framework. Is there a particular reason that you guys picked the titanium framework?
I think the main reason for using titanium is the guaranteeing, as evidenced by all of the arches, of a passive fit in a time-effective manner using digital technology. But, you know, that would be another thing to investigate. But I don't think, you know, I mean, most of us, when we're doing permanent hybrids, you know, Procera bars and things like that, people are using titanium as a base solution, and the flexion of titanium is also useful for the purpose of, you know, shock absorption and so on. But I don't really have, I mean, I can't guarantee that it's the better restoration.
As long as it's not zirconia. Zirconia is always a little bit risky for fracture for the full arch.
Oh, wait.
Any more question? Yeah,
Oh,
here.
wait.
Just a second.
Do you deliver the prosthesis under local anesthesia?
Sorry, Matt.
Do you deliver the prosthesis under anesthesia or not?
Good question. So most patients have the restoration delivered without any local anesthetic, and I tell them that they're going to experience a little bit of sense of pressure because the gum is a bit swollen, and we're just going to, you know, push it so that it fits nice and tight. Patients who are really, you know, you pick them already, or that I know that compression might be a bit more intense, I will give them local anesthetic. Or I tell them, if you find that this is too much, let me know, and we'll give local anesthetic. 9 out of 10 patients prefer not to have local anesthetic, and that feeling of pressure, I mean, of course, we can't be perfectly accurate about exactly how much we're compressing, you know, for the case. But generally speaking, it's something that lasts around, you know, 5-10 seconds as a more strong sensation, and then maybe completely subsides within 30 seconds.
Another question. Do you always use this straight multi-unit abutment?
Do I always use straight on the anterior?
Yeah, the multi-unit. Do you always use them? Because
Oh.
sometimes you can just, maybe
Go
fit in
to
the
implant
prosthesis.
level?
Yeah. straight
Yeah,
one.
no, they're all multi-unit abutments, and I think in terms of firstly the reproducibility of the system, as well as the simplicity of the multi-unit abutment level restoration, you're much more assured of getting your passive fit. I know cases where I've done 2 implant level. Of course, any slight angulation changes and all of that can bring in complications for the fabrication.
Okay. So we have to go on. I have a last question both on you. You mentioned a lot about the new design on the base of your restoration, which is very flat, yeah, not concave, not convex, yeah, very high polished, yeah. And I think it's not used, let me say, 2013 as you come into the MOI. So you have perhaps another. What is the difference? Do you see less inflammations, less plaque, or what is the difference? So not the technical complications. Do you have differences because you change the design on the base? What is your result?
When we have teeth set more anterior to the ridge, we can't achieve that sort of flat compression so much, so we do tend to go a little bit ovoid or a bit convex for those cases, sort of if we need a slight ridge lap or anything like that. But as long as we have the tissue thickness, which we try and achieve with the surgery, I think over the years, just the visual evidence has been that the flat compression creates a really nice outcome and less chances of having any alterations in the future, as well as the ability to floss and so on underneath should they need to.
Okay, thank you very much. So you get also your certificate. Please come up for a photo, and please settle up the next speaker. The next speaker is already here. This is master thesis, and it's Libor Michna from Slovakia, and he shows us also a workflow for single tooth restoration, and he measured the advantages or the similarities according to pain, how long it takes, with a chair-side CAD-CAM fabricated surgical guide. Libor, the stage is on you.
3 years ago, when I started my master's, I never had an ambition to stay on this stage. And here I go. So, ladies and gentlemen, if I can stand here, anybody can. And thanks Paul as well. I'm really honored and pleased to be here, and you pleased my wife as well. She's there, and my wife doesn't get pleased so easy. Well, thank you. Secondly, I need to disclose I don't have any conflict of interest with no company. No company paid me any money, no discounts, and we are going to talk a lot about Sirona CEREC. The title of my master thesis is long, so I'll cut it short. I just wanted to find out if I can place implants easy and better with the full digital workflow of Sirona CEREC, or without it, just barehanded in simple implant cases. Now it's evident that the future of medicine and dentistry in general probably belongs to digital technology and robots. These robots can diagnose and treat patients better today, never mind tomorrow. Now, we as a clinicians, if we can add some little extra value to this treatment, I think we are still okay. But the question stands, how far in this are we in the dentistry? I don't know, it's beyond my understanding. I'm not gonna answer to this question, but let me tell you a story which started about 6 years ago when I moved my family, practice, wife and 3 kids. Thank you for good behavior, guys. From Scotland, Glasgow to Bratislava, Slovakia. Believe it or not, but Bratislava is the 5th richest region within the EU with 200% GDP per capita. Only London, maybe Brussels, a few other cities surpassed it, not Frankfurt, unfortunately. Now, it's very competitive environment for new dentist who wants to establish brand new practice on a green field with no patients, no name, with patients who just pay privately. It's crazy. Actually, I wouldn't do that again. So you have to have some concept, some philosophy how to do it. So we decided with my wife to go with the newest technology. We bought CEREC from Sirona, despite other guys were saying and asking why you need this old new technique and equipment costly, you need to take a mortgage. Yes, I took a mortgage. Why you are buying this? You can place implants barehanded and without that much money. And yes, of course I knew what they were saying, because 18 years ago when I was starting my career in hospital, we placed implants with just the lowest quality OPG ever and no problem. But I'm glad for that, because then if I placed the implant with CBCT, then probably I wouldn't be able to place implants barehanded today. But despite that, we bought that technology, and I had the opportunity to find few answers. I didn't buy it for the CEREC 2. It was just the side effect. But I used it for this master thesis. So does it really simplifying things? The aim was to compare workflow from planning, placing, restoring implants with the CEREC. Compare duration of planning and implant surgery, post-op pain between implants, placed with help of CEREC 2 and without. 21 patients were with the whole digital workflow and 20 without the guide. For both groups, I assessed effectiveness, planning time, time of the surgery, errors, complications during the planning, milling, and the surgery. It was assessed in 2 parts. First part was to assess the position of the implant, did I place it correctly? And the second was the working time, which was divided into 3 steps. First step was the time of the software planning, second milling time, and third was the duration of the surgery. That was processed in 5 steps. First was the diagnostic phase with CBCT scan and intraoral scan meshed together with the virtual crown. Once you have a virtual crown, you can place implant virtually, and according to this create the CEREC 2. After this you can go to surgical procedure and then to fabricate the crown. So all I needed was the CEREC Omnicam, Orthoforce CBCT, CEREC mill machine, and some drill key sets, which I'll show you on this couple of patients. This was 42-year-old guy, bigger than me, with a heavy masseters, heavy occlusion. Actually, I think it was crazy to do such a case on him, but he was my friend from the boxing club. And I'm sure if something went wrong, he would beat me up, but my nose is still there. So he presented with this fractured tooth number 15. broken root, endodontically treated. My wife told me to take it out, so I listened to my wife to make my life easy. I took it out, but first I did the virtual crown, which was merged with the CBCT data, integrated together. Once you have these, you can go on, and this is actually the best part of it when you merge the bone hard tissue information with the soft tissue, because now you can see where you are, especially in these immediate implant cases where you want to preserve the soft tissue, because you know exactly it clicks like this where you need to place the implant, and if you place the implant in the way you plan, the case is won. So in this case I had just 2 or 3 mil of the space. I couldn't go too much farther here because there will be any primary stability and the sinus, so I went a little bit more palatal. There was no space mesolingual because of adjacent teeth. So once you have this, you can go on to the next step, which is establish the location of guide sleeves. You have 3 options: small, medium, large, and the drill stop. In other words, this means how big drill you need and how deep you want to go inside of the osteotomy. And once you have this, you can go back. This is Galileo software. And once you have this, you can go back to the CEREC and you play around with the software in the CEREC and creating this guide. It takes about 10-15 minutes to do this. Once you know how to do it, you just press the button on the milling machine and it mills guide out of the PMM block. About 30-40 minutes usually. So for any guided surgery you need this kind of kit. It's for every system pretty much the same, but this piece is I'm especially proud of because this was designed by me. That time I started like 3 years ago with this. There was no such a kit for the implant system I used. That time I think it only Straumann and other companies, maybe 1 or 2 more, had this kind of kit. So I printed it on 3D machine so I could do my master thesis. So let's go on with the case. I took the tooth out number 15. It's always a question how fast you can be with the extraction, but once you have this done, it's easy. Guide in, that key fitting into the hole of the guide in, drills, few minutes, implant in, and this is what was nice on that pre-op picture and scan, because I used his own tooth, not because I wanted to do any fancy stuff. I just wanted to be cheap, and actually the main reason was to fit and to plug the soft tissue, because if you do this, it fits into that just perfect and there is no tissue deficiency. This was 6 weeks later on. Of course the soft tissue is it's still premature, but nice emergence profile, no deficiency. I'm not the lab technician, but I did the crown on the CEREC. There was no, I don't know if there is a bone, but soft tissue is fine. I didn't use any bone grafts at all for this. All these patients, they're just simple implant cases. This is another case, the same protocol. Only difference is I didn't use the guide, because she couldn't, well, at the back probably I wouldn't be able to place the long drill along with the guide together. So I used the mesial root, But same protocol, extraction, placement. I used her own tooth, and she presented 5 months later on. She was from Switzerland somewhere, so she couldn't come in 6 weeks. She done in 5 months, but now we can see soft tissue, perfect, no change. So I did CEREC T-base scan, and then the new crown. So 21 patients done with guide, 5 of these with immediate placement, 8 with immediate load, 90% effective, and one of the third where I was able to load immediately. If I was placing probably noble active, I would be more effective, but by horizon this is not good for this. Yeah, so I changed it, but it did the study. 20 patients were done with no guide. Effectiveness was similar. So I measured the duration of surgery. The surgery was faster with guides, on average just 2 minutes. Just 2 minutes. But of course you have to add planning and milling phase to this. The overall CEREC Guide 2 workflow times were greatly reduced as the familiarity and the use of the software increased. This shows the peak at the beginning, how I was struggling to learn how to use the software. It took me hours, 2-3 hours to do it, and then it went constant. It took me 60 to 70, 80 minutes. Then, so this is total time with CEREC Guide 2. And this is the comparison of all those 3 steps I showed you at the beginning. It shows that the most time consuming part is milling, and the peak is showing the complication with the milling machine. It was quite often the debris of that block stuck the channels of the machine, and a big flood, and the drills, breakage and fractures, and it was nightmare sometimes. Yeah. So this is the comparison of the planning, guided and non-guided. Of course, for the guided, I didn't plan for the software, for the guide. So this is showing, oh sorry. So this is showing 15 minutes difference I used for the software planning. So this is just comparison of the surgery times, 2 minutes only in general, and this is the comparison for the total time for both, which was about 40 minutes, 50 minutes maybe. Sorry. Yeah, this is 40-50 minutes. So I measured the pain for both groups. Patients were asked about the pain during the first 3 days with the visual analog scale 0 to 10, with minimal pain starting from 0 and the highest imaginable intensity of pain ending at 10. When comparing patients of both groups with post-op pain, there was slightly higher scores in patients with guide, but this was due to the fact that in 2 patients they developed aphthous stomatitis for some reason, 2 days post-op, and then complained about the pain like hell. Otherwise, there is no difference between these groups. So I compared pain between all these groups, even the subgroups. I did the crestal incision, punch, immediate place, and we tried to compare it, everything between among each others. I don't want to bother you with all these boring statistics because it's the same, but let's wrap it up. Based on the result of this study, when we compare 2 protocols of immediate placement and load with the guide and with no guide, immediate loading of the implants with guide was more often possible. The time needed for the fabrication of this guide is about 1 hour, with the cost of that block 50 euros on average. That doesn't include the time, burrs, and all equipment needed. On the other hand, the use of a digital pathway may improve customer satisfaction, and this I used quite heavily. The TV crew came to my office, and they did the program about the software planning and everything, and they patients were ringing like crazy and asking me to do the 3D crown for the crowns I couldn't do 3D actually. So I was in trouble. So you use marketing leverage, which I needed actually. Yes. The time was shortened by 2 minutes only, so it seems that this difference is not relevant. But the question may raise when the guide is used, but not a very experienced surgeon or a beginner, it may rise. The pain intensity in group 1 was higher, but this was much deviated by after stomatitis in 2 patients after 2 days of surgery. In both groups, the result shows tendency that flapless is less painful. This technique is feasible in private dental clinic. It's easy and relatively cheap to use chairside once you have invested in all the equipment. There is no need for dental lab. Every step can be achieved chairside. CBCT scan milling machine can be used in many different ways in general dentistry. I didn't buy this stuff for guide 2. I used it in many different ways. Sirona claims that dentists have complete control of the single tooth implant process from beginning to end. But this is partially true just in the single tooth gaps, good for the stability of the guide, adequate opening space for the guide, and elongated drill access. However, this specific Surrey Guide 2 is still missing the key factor in digital pathway, and that is to have the possibility to produce the crown before the actual surgery, just based on the information from the pre-op virtual proposal of the crown. Conclusion. There were found no obvious differences between conventional and guide implant treatments. The use of digital pathway may be used as a certain marketing tool, although the initial investment cost is high. That's the end of it. Thank you very much for your attention.
Thank you. Thank you very much, Libor. Yeah, this is your really unique own style to present. And I was very impressed because we decided not to sponsor this Congress, and it gives a lot of problems because yeah, money is always an issue, but we don't have any booths of Dentsply or Sirona, and therefore you can tell here really the truth. Yeah. What happens really, and you show it very nicely that yeah, it's a marketing tool, but in the daily work it's not giving you a big advantage. Yeah. And I'm happy to hear this, yeah, because you said in the beginning you're completely unbiased. Thank you for this kind of unbiased presenting the data. Thank you very much.
You're welcome.
Is there any question to him? Perhaps some of you have also the CEREC machine doing the same protocol, has completely other different experience. Wait a minute, because...
How did I fix the milling problem? Yeah, how did I fix the milling problem? Yeah, I cleaned the debris and did it again. What can you do?
Yeah, he tells the truth.
Personally, I think there's a flaw in the milling chamber, and I've been working.
No. The milling chamber didn't get flooded with the debris. It was just.
It literally plugs a hole.
Mean? Yeah, I took the caps and cleaned it. Just use common sense. Clean it.
Okay,
Did it again. Do it
I've
again.
been trying to work with Sirona to lift. There's a little basin at the bottom. They can create some space.
You have to be careful not to flood the.
Yeah, I've
water
had
inside.
probably 10
Don't
floods
do
in my
that.
office because of this.
I wouldn't do that.
Yeah.
Just gently spill it out and collect the debris, and you can start it again from the beginning.
Or print
But
the
that
case.
happens only when you do the blocks in a row. It never happens within one block when I was doing in more patients in a row.
In July, right? Yeah. Last year. And yeah, he come from Brazil, and he see the idea to place implants in a socket and seal the socket. You know the story. We start very early with this kind of approach, and he want to know it exactly in the posterior region after you extract molars. And of course, in a molar you don't need a full crown. He make so-called anatomically shaped healing abutments, and he want to assess how it works with the soft tissue in the bone. Good. I don't know this building. It's not in Brazil. It's not in Brazil. Okay, please start to present your master thesis.
Okay, thank
Very
you.
happy to hear it.
First of all, thank you, Professor Paul and MOI staff for inviting me to be here. It's such a great honor. Okay. Such a great honor for me to be here, present my master thesis. And I want to start my, I'll tell my name in a second. Okay. I want to start my presentation with this recent picture of a patient of mine. Actually, it was taken 15 days ago, and he came for his regular dental visit. We usually call the patients to do so. But at this time, he was a bit disappointed with his molar crown 4-6, which was done the year before in my clinic by me. And in his own words, the tooth was out of the gingiva. There was a step here, and he thought that the tooth was not properly seated over the implant. And I think that is it's very slow. Sorry. Yeah. So the step here, and unfortunately I could only agree with the patient. The case was not good, although biologically healthy. We had recession in comparison to the adjacent teeth, and also velar process deficiency. This is maybe if you change the control. Yeah, sorry. Well, I could only agree with the patient, but the problem is that this case was done after completion of my master thesis, and I applied all the rules I found in my research to be the best option for this kind of case. I can tell you in advance that the test group with grafting materials were better than the control group without grafting the jumping distance. So what happened in this case? Bad news. The protocol I'm going to present to you is not suitable for all cases, and there must be other variables involved, and there are. We're going to discuss it a little bit later. But the good news is that I learned a lot from the process, and I'm going to show the results of the 14 cases of my master thesis. But I've been doing that a long time since before MOI, and so I decided to go further. And now I have evidence that I have the doubts which was the best option for this type of case, and now I have evidence that one option is better than another. This is so my name is Marcio Carrera. I'm going to talk about static outcomes of the soft tissue and bone level changes in molar immediate implants. what interferes positively or negatively, and try to set a set of synchronized actions to try to somehow counteract the innate modifications that occurs after tooth loss. Few words about myself. I live in the southeast part of Brazil, in a city called São José dos Campos. It's a middle-sized city, approximately 700,000 inhabitants. It's a very well-located city between the two most famous, Rio de Janeiro and São Paulo. But still, it's unlikely that you have heard of my city. But it's probably that you have flown in one of our aircraft manufacturer at Embraer. Embraer is one of the biggest companies of the aeronautic industry and has been recently overtaken by Boeing. So the outline for today, we're going to discuss some literature review, material methods, the results and the statistical. I'll show the discussion and the conclusion and talk very quickly about other variables. When it comes to a fresh socket, some questions arise from this. And what happens after extraction? What's going to be the final shape of the ridge after that? And more importantly, how long does it take? Some literature review, some changes occurring after extractions were addressed by many authors. For example, Araújo, which one is it? Oh yeah, Araújo, which is a Brazilian researcher, and he talked about 3 overlapping phases: the inflammatory phase with cell migration to the area to clean, the proliferative phase with deposition of provisional matrix, modeling phase mostly in the first 3 months, and remodeling that can extend for over a year. We have quantitative and qualitative modifications in the alveolar process. The alveolar process is developed in conjunction with tooth eruption and is dependent on that. So whenever the tooth is gone, it's going to change. We have reduction of socket walls concerning width and height, and the buccal aspect of the ridge is going to be the most affected one. Some immediate consequences are loss of mucosal contour and center of the ridge shifting towards lingual or palatal. How long? The majority of the changes occurs within 3 months. But as said, the remodeling phase can extend for over a year. And for my master thesis, I did the follow-up for only 3 months due to time constraints. But recently, I got the results from 18 months, and I could see, I'm going to show you that maybe the remodeling phase played a role in the changes. Despite all the changes, the placement of median implants allow proper clinical healing, is very effective. We have high survival rates, as seen in these articles. For example, 97% by Lang in 2012. Some advantages said are less surgical interventions, shorter treatment time, proper 3D positioning, and predictable functional and aesthetic. As disadvantages, we can cite increased risk of recession, and that is unable to prevent modifications. In other words, the placement itself of the implant does not interfere in the natural flow of events described after extraction. There's no ideal approach. Many authors have cited different techniques, materials used to counteract the modifications, but to our knowledge, there's no consensus over an ideal method, and that's why the complex intraoral phenomena after healing is not related to just one or another variable. So we had to define our approach with flapless surgeries for minimally invasive procedures. We used an implant with a geometry, a taper implant with a geometry that favored the prime stability. And this was crucial, this was critical for success because it allowed the usement of customized abutments on it. And the full protocol is that one: flapless approach, minimally invasive extraction, some diameter and taper implants, use of customized abutments combined with either grafting or not. The hypothesis was that the use of customized healing abutment could provide tight sealing of the socket entrance, creating optimal conditions for resolution of the marginal distance around implant without bone grafting. In other words, the use of customized abutment alone could maintain the soft tissue architecture, and then yield a aesthetically acceptable clinical outcome. The material method, we got ethical approval from São Paulo State University. We asked for patients with a hopeless molar tooth. We could gather 14 patients. Each patient was given an envelope and was assembled to either the test group or the control group. The test group with customized abutment and grafting, and the control group only customized abutment. The inclusion and exclusion criteria was the following. Standard ones, not very different that we found in the literature. Not go further on that. And so we started the process. In the stage 0, before implantation, we called the patients for clinical evaluation, anamnesis, historical medical history, and also we asked for some laboratory exams. We did the photography protocol, intra and extraoral. These were very important for future comparison. We asked also for the digital exams, OPG, the periapical X-ray, which was we used it for assessing the vertical interproximal alterations, and obviously the CBCT for planning and diagnosing and planning the implant. At the day of the surgery, I assessed the gingival biotype with a periodontal probe before the extraction, and after extraction I confirmed that with a surgical caliper. The threshold was defined in 1 millimeter. We performed minimally invasive extractions. In this case I used the surgical bores for root separation. Very delicate instruments were used for elevating the remaining roots. The use of forceps was avoided, especially the buccolingual movements, in order to preserve the usually thin buccal plate. But in cases after root separation, the remaining piece of tooth was eligible for rotating movements, we could gently use the instruments. When applicable, we used the Benex system for extracting the molar teeth, and the Benex, as you all know, applies no forces in the surrounding walls. So the immediate outcome is very good. So we have very preserved soft and hard tissue. Unfortunately, I didn't have the smart drill of Professor Paul, but I did follow the manufacturer's protocol for implant bed preparation. Then we placed the implant. The vertical position was defined according to the gingival margin, 3 to 4 millimeters apical from that. For fabricating the customized abutment, we used these collagen sponges around the abutment and the implant to protect and prevent the flowable resin, which was the material used for customized abutment, to go deep into the socket. After capturing the abutment, we detached the set, and we started the chairside customization. Finally, we applied the polishing sequence, and this was the final stage for the control group, with placement of the customized abutment over the implant and sealing the socket. In the test group, before doing that, we grafted with bios particles up to the neck of the implant. And this is the final lateral view of immediately after placing the customized abutment. And also, we did the X-rays after placing the implant. This is a subject from the control group. We can see the void here. And also the subject from the test group with the bone minerals in the void. Next stage, actually is stage 2, sorry for that. The follow-up and prosthetic phase. All patients went under a follow-up period of 90 days. And then we called the patients to remove the customized abutment, make all the photographies, the assessments, and also start the scanning for prosthetic phase. So this is a specimen from specimen subject from the test group. You can see the particles here, and here subject from the control group. We can already see some buccal contour deficiency here. The prosthetic digital workflow, I used the CEREC system, and the crowns were milled and delivered at the same day. We did the occlusal contacts checking, and this is the final, the crown seated over the implant, just immediate photography. 1 week later, we called the patients again for PASS, pink static score, and X-ray evaluation. So we used these lateral pictures, lateral photographs for assessing, and also the occlusion ones. We used this, as said, the pink static score by Furhauser, published in 2005. This pink static score evaluates 7 parameters: mesial papilla, distal papilla, level of soft tissue margin, soft tissue contour, alveolar process deficiency, soft tissue color, and texture. And to each parameter, you can give 3 possible scores: 0, 1, or 2, in comparison to the original tooth or the adjacent teeth. For interproximal hard tissue level assessments, we used the digital rule of the X-ray software. So we measure from the base of the implant to the, this is the same case, to the crest. And the results and statistical. We defined the p-value in 0.05. The statistician used the Mann-Whitney test. I really don't know why, but and demographic data, the mean age was 43 years old. Age ranged from 24 to 65 years old. 6 male, 8 females, no smokers, and the groups were considered homogeneous for the study. The reasons for molar loss: we got 50% of the cases due to untreatable caries. 5 cases root fracture, and 2 cases endodontic failures. We placed the implants in almost every molar region except for regions 27 and 37. The region 46 was the one with most cases, 4 cases total. 50% of the cases got bios, particles, and 50% none, only the customized abutment. We've got 100% survival rate after 3 and 18 months follow-up. And with regards to hard tissue alterations, the test group presented slightly less interproximal loss compared to the control group, but the differences were very subtle, both in 3 months and 18 months follow-up, and didn't reach statistical significance. For example, in the 3 months follow-up, we got minus 0.72 in the control group and minus 0.52 for the test group. After 18 months, we kind of had some stability in the numbers of the test group, and the control group numbers were slightly higher, but again, not statistically different. Here you can see the graphic. You can see the difference. The gray ones, the control group, and the yellow test group losses. This was not originally in my research, but I found it really interesting to add. That was the gingival biotype frequency. We found that 57% of the cases were thin biotype, and 42% of the cases were thick biotype. When compared the gingival biotype versus the PAS score, we didn't find any difference. So we gathered all the thick patients, and compared to the thin patients, we didn't find any difference. However, when we analyzed inside the groups, for example, in the test group, we compared the thin biotype with the thick biotype inside the group, then we found more significant difference, but again, due to the low n number, number of cases, it didn't reach statistical significance, both in 3 and 18 months control. Maybe with more patients we could see some differences. With regards to the pink status score outcomes, we found that it ranged from 8 to 14 in both 3 months evaluations and also 18 months evaluation. But the interesting thing is that one case got higher PAS score after 18 months. 8 cases got the same PAS score and 5 cases lowered the score. The mesial papilla was the parameter with most scores too. 85%? Yeah, 85%. But it was after 18 months follow-up, because in the first evaluation it was 100%. So we possibly due to remodeling, we did see some decrease in the parameter numbers. The level of soft tissue margin was identical to the original tooth in only 3 cases, 21%. And all of those cases were from the test group, fake biotype. The alveolar process deficiency was the only parameter that got score 0, 2 cases, both from the control group with thin biotype, and in 64% of the cases we got a small discrepancy in the buccal contour deficiency. For the soft tissue color and texture, we found 78 and 71% cases identical to the original teeth. The PAS parameters between groups showed that only the alveolar process deficiency reached we got statistically significant differences only for this parameter in both 3 and 18 months follow-up, but every parameter compared individually was at least equal or better in the test group compared to the control. Also, the total PAS score between groups was statistically different in both 3 and 18 months follow-up. But it's important to notice that all scores were reduced after the second evaluation. Discussion. The outcomes of this investigation showed that the customized abutment alone was less effective in promoting soft tissue maintenance around the immediate implants when compared to the sites where grafting materials were added to the jumping distance. The alveolar process deficiency was significantly more present in the non-grafted group, impairing the buccal contour of the molar restorations. And on the other hand, the grafted group presented better results and seemed to limit better the horizontal reduction, and then yielded better results. However, the level of soft tissue margin, however, was reduced indistinctly of the groups. So most cases we got some loss or level of soft tissue margin. The level of interproximal bone, we could see a trend in this study that the grafted group presented higher PAS score with less interproximal bone loss. But again, the differences were subtle and didn't reach statistical significance. After 18 months, we could see additional loss, maybe due to remodeling. A limitation of this study was that the PAS score is based on evaluation on visual basis, so it cannot magnify whether the modifications are related to soft or hard tissue alteration. So I couldn't measure that. But the control group without graft presented constantly more perceived modifications, especially in the buccolingual measurements. So within the limits of this study, the proposed protocol for the immediate placement of implants is flapless approach, minimally invasive, taper implants, customized abutments, and grafting the jumping distance. The conclusion is that the anatomical healing abutment is able to limit but not avoid the overall contraction of the horizontal and vertical dimensions of a post-traction socket. So it it got good results, more than 9, which was defined as clinically accepted, but the grafting procedure of the marginal distance provided more predictable outcome. Not to forget, this was not addressed in my study because I couldn't measure the buccal bone thickness, but it was in my literature review, and these 2 articles, they say that the thickness of buccal bone is a really important key. We must pay some attention to that, and apparently the thicker the buccal bone, the less perceived alterations we find. Also, I think we should go digital nowadays to get better results, as the previous presenter said. This really helps us. I always use software planning for creating my own surgical guides, and I know I'm talking about single implants, but whenever you do by eye, you are more subject to mistakes. So using a surgical guide, even for single implants, is really good. If you place the implant in the wrong position, you can impair your final outcome. This is anterior case, but I use it for everything. Also, the CAD/CAM blocks available now in the market are really plays an important role. I've been using a lot that. And I think the adhesion of the material to the soft tissue is different from the flowable resin. I did in my master thesis, so I really think we should think about that. And back to my patient, I found the original picture of him before implant placement. And taking a closer look, we can see general recessions, thin biotype. If I could go back in the past, I would probably advise him with regards to overbrushing, and also at least suggest connective tissue graft by the time of implant placement. He didn't accept to do this now, and the only thing I did was remove the crown, did some polishing, remove this step, and he's happy again. For me, it's not good, but okay. This is my clinic. This is where all my patients were treated. My family, new member, and I'd like to thank you all for your attention.
Thank you very much. Thank you very much. Yeah, very impressive presentation about your master thesis and about your results, comparing grafting versus non-grafting if you try to reach a so-called primary healing by closing the wounds perfectly. Really good. Is there any question? We open the discussion on that topic. The old story, should we grafting or not grafting?
It's not really a question, but in terms of analyzing the changes in the soft tissue, could you have taken, because you took a scan before, could you take a scan after and overlay the two and be able to calculate it volumetrically?
Yeah, it must be possible. I haven't thought about that, but yeah, I don't know how to calculate the differences, but...
No, neither do I. I just got a scanner, so I don't know exactly how to use it yet. But I'm thinking that would be something that you can truly quantify in 3D, right?
Yeah. This is a very nice measurement that we have 2 scan data of the albal ridge, with or without tooth, and then there are software programs you don't have, but university have, and then you can overlay, like you match a cone beam CT with a scan, then you can see what is volume gaining or loss, and then you can also see the loss, and this is also one of the parameters of the Fürhauser score.
Okay.
Yeah. This will be nice if you add next time, you know?
Hi, I'm wondering, those are amazing photos you have. Are they your patients? Are you taking those?
All my patients.
Wow.
All my patients.
Fantastic. I don't know why your patient's so good looking and how can you're such a good photographer. Brazilians have such a
we usually do some photo shooting after treatment. All my patients.
That's fantastic. You're a good photographer.
Yeah, you're a bit distracted in the lecture, yeah? Yeah. Okay. David?
There are some companies now that are creating templates for specific sites. So you place the abutment inside the template, and then you just put flowable around it, and it's suitable for an ideal emergence for a 1.6 or a 2.6 or whatever it may be. And there's also somebody posted recently on one of the implant forums online. They CAD-CAM produce these abutments before the treatment.
Yeah.
Based on the tooth. So they do a 3D scan, CT scan, and then they cut the crown off digitally and design the CAD-CAM abutment.
Yeah, I'd love to have that.
Yeah. And you mentioned the CEREC as well, because you can obviously do that with CEREC.
Yeah.
Teleo CAD and just cut it down to the gum level.
Yeah, it's in layers.
I think also that your procedure, you start your master thesis to make it by hand is okay, but what you see already, we have other options to prefabricate a little bit or have a mold or so. But this will not change the results, I think, yeah, because this is only a manufacturing feature.
It takes more time.
Like that and that.
Yeah, it takes more time and it's costly. My wonders are whether the materials plays a role or not in the adhesion, because you know you can polish the flowable resin, but I don't know if it's the same thing of CAD-CAM block.
Your question?
Marcio?
It's working?
Yeah.
It's possible to use CEREC to mill a provisional crown,
yeah,
PMMA, doing the emergence profile.
Yeah, it's possible.
It's possible. And it seals good.
Yeah, it does. We do that a lot. So we scan, we remove the tooth, and then we scan. Then I finalize my procedure, and my partner does the copying and the crown in layers. So you do that in two pieces. Yeah, yes. Multi-layer.
No, I'm asking you because the PMMA, it's better than the acrylic resin to get polished. It's only this that I'm asking you.
Yeah.
I think it's a better you will have a better result, or you can try to have a better result than doing by hand.
Yeah, no. That's my next step. That's my next step.
Okay, I have to finish the discussion. Okay, one more, the last one.
Okay, in case of buccal bone dehiscence, do you still place immediate implant on the molar?
Wow, that's a tough question. We can sometimes I place, yes, and then I use a different xenograft like bios collagen to try to preserve the architecture of the place. But yes, I do, even if I don't have the buccal bone. For molar, maybe, but in the anterior, no. Only bios collagen.
Okay, thank you again for your great research.
Thank you.
Very nice presentation. Perhaps we can license one of the photos for the Master of Aesthetic Dentistry. And I'm happy to come, that you are coming here to present your data from your pilot study. So, the stage is on you.
So, hello everyone. I know you are tired, but I will try to entertain you with my presentation, not to bother you. And I would like to thank you, Paul, for the invitation. It's an honor to be here presenting my topic that is very similar from Marcio, also my colleague from MOI 12. So I would like to also thank you for being here, MOI 12. And my topic is customizing the mounting device of implant system to preserve the biological shape and bone formation in immediate implantation, a pilot study. So I will start with some background. And we know major changes occur in the alveolar when we pull it out the tooth. And within a year, we have 5 to 7 millimeters of loss. And the first 3 months, we have 2/3 of this reduction. So we have to compensate this reduction. We already know this reduction will occur. So we have to compensate with some techniques, with some surgical techniques to avoid a disaster. So when we place immediate implants, we don't raise a flap. So we don't cut off the nutrition. And this is a technique to avoid problems in this area. And the immediate implantation also has some other advantages that reduce treatment time, reduce the surgical intervention, and we have a great bone availability. Primary stability, of course, is fundamental for immediate implant placement and professionalization. We have to achieve primary stability, as Paul Weigel showed to us yesterday. And of course, lack of micro movement is also important to achieve also integration. So we have to achieve this primary stability to use this technique and prevent problems in this area. And also, of course, we have to select implant system, geometry, who have some aspects to prevent micro movement and to achieve the primary stability. And the Ankylus was the system chosen for this case, for this topic. I already used Ankylus before MOI, and that's one of the main reasons I am here. I applied to this program. And Ankylus have the progressive thread design and the square threads who guaranteed, or you can rely on these threads to obtain the primary stability. And the customized Healy abutment, since the year 2000, it has been used to maintain the original gingival contour and to transfer this to the final restoration. And in 2010, there is a paper from Dr. Georgia Trimple with Paul Weigel and all the teams here from Frankfurt. And they said that the capitated provisional restoration acts like a customized Healy abutment to preserve the biological emergency profile. So I've been doing this before MOI, and this was the paper I started to realize that I could go further with what I was doing in my office. And then we have another paper from the GIRI that describe the chamber concept. So we use a customizing Healy abutment as a ceiling of this chamber. So we have the implant with the floor, we have the walls, and we have the ceiling with the customizing Healy abutment to let the implant heal undisturbed. And this is the chamber. And then we proposed a customized Healy abutment to act as a temporary abutment and of course maintain the original gingival shape. And we aim to seal the socket, to seal the alveolar socket with this customized Healy abutment. Of course, we aim to proper transfer the emergency profile to the final restoration and to provide a chamber allowing the blood clot to turn into bone and fill the gap, fill the jumping distance. The idea of this work, because I don't work with prosthesis, I don't do the prosthesis, I do the surgery and I have my referrals. So I was thinking in how could I enhance my emergency profile, referring these patients to the prosthetic phase. So how could I, as a surgeon, could I improve the emergency profile of my patients to my colleagues? So I decided to use the Ankylus system. I decided to modify the carrier device in order to use this carrier device as a temporary abutment for this work. And we started to hypothesize that not graphing the space in between the implant and the extraction socket using a customized Healy abutment to seal the socket will lead to the same formation and stability of bio-os. This is our first hypothesis. And using this mounting device, modifying this mounting device, using it as a temporary abutment and the customizing Healy abutment would lead to better aesthetic results compared to a normal gingiva former. So the patient was grouping, it was a random selection, and the inclusion and the exclusion criteria was the same we are used to see in the literature. The patient must be at least 18 years old, diagnosed as a hopeless tooth to be extracted, and the exclusion, of course, any medical contraindication for dental implantation. And this work was approved by the Brazilian National Ethical Committee. I take 2 years for this approval because I was planning, I planned to do 2 CT scans, 2 CBCT cone-beam CTs, with the interval of 5 months between them, and this was a little bit difficult to get approved, but I did it. So it takes me 2 years, but I did it. And here are the test group, and I took an X-ray from all the patients just to see the distance from the alveolar nerve, from the apex, the apex of the roots to the alveolar nerve. And the test group was extracting the tooth, of course, minimally invasive extraction, placing an implant, not graphing the jumping distance, and fabricate the customized healing abutment. And the control group, the difference was that the gap was filled with biowalls. And here is the criteria we observed. We used the pink static score and the T0 and T1, and use the cone-beam CT to compare the bone, the changes of the bone in these 2 moments. So the pink static score to evaluate the soft tissue, and the cone-beam CT to evaluate the hard tissue. So here what we find in the cone-beam CT, we started to measure. Here we started from drawing the vertical line in the middle of the implant. Then we draw the first horizontal line, and the other lines were drawn 3 millimeters distant from each other, and we could measure the width, both lingual and buccal. And we can see here the changes that occurs in the buccal bone. We are used to see these changes. Here were the patient pool, and the mean torque was also calculated. So I could have placed implants only in the mandible. It was a little bit hard to get the proper patients to fill in the inclusion criteria, because I have to place an 11 millimeters implant. So it was difficult to get more patients. So we couldn't get 4 patients. That's why we changed for a pilot study because of the sample. So here the pink static score, and if you see here the pink static score variable from 8 to 14, and there was not a huge difference, except for the patient 3. He was 13 in the pink static score in the T0 in the baseline. 5 months later, we have a score of 8. And the CBCT measures, I measure the bone, the buccal at the implant shoulder, 3 millimeters, 6 and 9, and the lingual, the same parameters. And if you look here, the patient 3, we have different values. It was a hard case to manage, and we have the major alterations in this patient 3. And despite we have those different, when we apply the statistical, there was no significant difference found in these 2 groups. And the discussion, we have since 2000, the shape and transfer the pale implant soft tissue contour. We can use the customized healing abutment to do that. The customized healing abutment can preserve the original dimensions and the soft tissue. We can improve the soft tissue thickness, and we can enhance the emergence profile in peak aesthetics using this customized healing abutment. So the literature is in our favor. Recently, in 2016, Aiken said there were the customizing healing abutment you can use in the use of this device is justified by 3 main reasons. One, we have the flapless approach. Two, the use of stock abutments demand flap raising, and we know that will injure the nutrition. And usually the emergence profile is not properly scoped by the lab, so with the customizing healing abutment, we can keep the original gingival shape. And here I use a flow composite because the acrylic resin, as the colleague asked Marcio before, the acrylic resin causes irritation to the tissue, and I use flow composite just because of this reason. So the flow composite causes less irritation than acrylic resin, said by Al Harbi in this paper in 2007. The polishing and the finishing is better on the resin and is easier to obtain. And the pink static score was used to analyze the soft tissue changes, the pink static score by Fühlhauser. So in our present study, the customized abutment was used to seal the alveolar socket. We could seal the alveolar socket. The flow composite was used to fabricate this device, and the pink static score demonstrated the maintenance of this original gingival contour. So we are able to keep this original contour. And of course, the emergency profile was properly preserved by the customized healing abutment. The implant place as soon as possible after the tooth extraction is an advantage. Since 2003, Schurup had said that. So when you can place immediate implant, you go for it. Immediate approach can reduce treatment time and decrease the amount of surgery. Implant with narrow diameter in larger gaps can reduce the rate of vertical bone resorption because you can augment it more, you have more space to augment and to preserve these losses. Short and narrow implants show similar cumulative survival rates compared to large and wider ones, set by Misha Krebs. And avoid micro movements under loading condition to reduce bone, of course. Implant stability is a key to obtain the providentialization, to get providentialization. And several studies are favorable to gap filling in order to prevent vertical and horizontal bone loss. So the literature always pushing us to fill the gap, You have to fill the gap with some materials. And major bone loss when the thickness of the buccal bone was less than 1.4. So when you have thin bone biotype, you have major loss. The soft tissue thickness might influence the gingival recession. Of course, if you have thin biotype, thin gingival biotype, we can lose more. We can have more recession than a thick biotype. And the chamber concept is important to obtain an undisturbed healing. So in our present study, what did we do? Immediate implantation, flapless surgery, narrow and short implants were placed into the molar area to have larger gaps. Customized healing abutment was used to seal the socket and create this chamber. And we have two groups, one filled with bios and the other one with the blood clot. And there are no significant difference regarding the gap filling between the groups when we apply the statistic. But when you look to the clinical results, and we are clinicians, we see that the gap filling is better. We have better results in gap filling with bio-was than relying only the blood clot. So the bios or biomaterial can act physically as a barrier to prevent external forces, and this prevention of these external forces can lead to better results. So the conclusion of this topic was they use a customized healing abutment fabricated by modifying the mounting device of ankylus. So we placed the ankylus implant and we cut the carrier at the same level of the gingival margin, and then we apply the resin to build the customized healing abutment. And this customized healing abutment could indeed preserve the biological shape and transfer this biological shape to the final restoration, and leads, of course, to the better aesthetic results. And The spacing between the implant and the extraction socket using customizing healing abutment can lead to similar bone formation and stability when compared to bios in cases where the soft tissue is thick and you have no bone defect. So when you have a molar area with good bone biotype, with thick bone biotype, thick gingival biotype, you may rely only on the blood clot using a customized healing abutment. But if you have a defect or you have a thin biotype, you have a thin buccal plate, it is better to fill the gap with biomaterial, and this gap filling will improve for sure your outcomes. So I would like to thank you all for your attention, and discussion is.
Thank you very much. Thank you. Really great. Yeah, this is always the same story. If you make a master thesis, you don't have so much time, especially for the ethical approval. So we are deciding, mostly we have a pilot study, but I really ask you to continue, that you have 10, 15 cases, especially with the cone beam CT, to get more power in your statistics, because, you know, for patients gives you only a hint, and this is a reason for a pilot study, but very nice structured. So I open the discussion on this presentation. Yes?
It's open, yeah. A question for you, sorry. How you manage the flowable composite when you are making the healing abutment not go too deep? Yeah.
I made an aluminum foil to prevent the flow composite to get into the socket. So I used the aluminum here underneath, and then I applied the resin, light cure, applied a little bit more, light cure, apply a little bit more, because you have to control the blood in to make the customized healing abutment. So if you do only one time, you may have blood mixed into the flow composite. So you have to do in steps, and you use aluminum foil to prevent this.
Yeah, it's working.
Actually, a question for both of you and Marcio. That's what's in mind.
Go, Steve.
When you have an extraction socket, especially in the molar region, the S-curve coming out of the implant, and you guys both use two different types of implants, right? Anklos having a much more narrow connection, Marcio active with a wider connection. One distinct difference that I noticed is that with Marcio's case, you used a tie base, and it has a very, very steep kind of emergence. But with an anklos, it has a much more narrow curve. How did you determine what type of curvature that you wanted to get based on the depth of your implant? So for Marcio, yours case would have to be starting out from the platform of the tie base, whereas you would have, Arthur, yours would be a much more gradual curve. Would you predict that that would have some impact on the type of bone healing in that socket?
Okay, this is determined by the position of the apical position of the implant, the apical coronal position. So if you place the implant 4 millimeters to your future gingival, to your future crown margin. So you have a crown, and you know where the crown should stop. So you have the lower margin of your crown, and then you have to place the implant 3 to 4 millimeters below this measurement, and you get the proper emergency profile for this crown. So that's why I determined this curve you asked with the customizing helium, but because the position of the implant follows this pattern. Yes, and then you do this design.
I just followed the abutment curve, and the vertical position was the same, 3 to 4 millimeters vertical to the margin, gingival margin, and then I just track it. And the same with the CEREC. If you do it in the CEREC, you can really like make it really. You can add material, but you can really make the whole thing. You touch the gingiva, the soft tissue, on the first 1 or 2 millimeters, but below that, I want to say that. Yeah.
Mm-hmm.
You don't have bone all the way around the implant, or you've got a socket on either side of the implant, so the tie base does come out very abruptly. Compress the bone.
Paul, can I ask a question?
We have a new guest in this room, and I want to introduce him after we finish here. But he has a question, so I have to do it ahead. This is Professor Dr. Adi Palti. He's the vice president of the ICOI internationally, and then in the German he's a president. And he is giving tomorrow all these exams, and he's also the person who really pushed forward the cooperation we have between MOI and ICOI, that you can also get this exam and the fellowship here. You see also from the next lecturer that it's working together. But now, Adi, you can ask your question.
I have an interesting question for you, because you did a beautiful job comparing augmentation, bio-os, and blood clot. I just want you to follow these cases, because when you have a blood clot, you got natural bone. When it healed, it's natural bone, vascularized, perfect. When you put bio-os or whatever material you will call it, it's never vascular bone. After 18 years, we found the same material.
Okay.
And we are going to present in Las Vegas in 10 days a research with FDI, 60 dentists around the world, 10 years research, peri-implantitis. So you have to think about what happened to the material if it's not natural bone, because a small infection into the bio-os will give you more trouble than in a natural vascular bone. So it's maybe a short-term thinking, but follow your cases and you will be surprised. So personally, I think that the blood clot, if you have the same result, why buying material from a company if you have the same result?
Yeah.
So just think about it. Don't let them manipulate you.
Thank you.
Okay, so we have to finish the discussion. I want to hand over you the certificate. Yeah, and this is the main topic in the whole course. Yeah, what is the indication for grafting and not? What can blood? Because we know the native bone has the biggest strength against any infection later, any kind of immune deficiency. If you come later in the status that you get the transplantation with immune suppressive medication and so on. And implant works 20 years. You never know what happens in 10, 15 years with your rest of your body. So I have a next topic which is more or less similar. Yeah? He's making a master thesis on the topic you see already, should we graft or should we not graft the sinus floor elevation? And is Muniz Mukhtar coming from Pakistan, yeah? And I'm really happy that you do this lot of work to present here, to come here.
Thank you very much.
Unfortunately, you are the last one, but somebody has always been the last one. But you have the advantage, yeah? You can refer on every lecturer, and nobody can tell anything more after you, yeah? This is the little bit advantage if you be the last lecturer.
Thank you very much.
Okay, please start.
Good evening, guys. I have one good news, that it's a short lecture. And one bad news, I'll try to make it the best, although normally they say the best things comes in the last. I'm not really sure, but I'll try to make it short and sweet, right? So let's start. Okay, this is not Switzerland, this is Pakistan. We have very beautiful northern areas. I just like to introduce a little bit about my country. We belong to the country whose president is a dentist. That's the only country in the world. The current president is an American diplomat of prosthodontics, American diplomat of orthodontics. He's a Michigan graduate, and he's the president of my country. My prime minister, he's a very well-known cricketer. So we have these kind of people leading our country. We are very optimistic and hopeful that they'll lead us to some good ways. We have something little bit about my country. We have the port, that's the largest and the deepest in the world. K2, it's the second largest peak in the world. We have that in my country. This is world's longest glacier system outside the polar region. That's Biotype Glacier. That is in Pakistan. And Islamabad, that's a capital. It ranked the second most beautiful capital in the world. Now come again to the topic, introduction. Okay, that's a reality, man. Okay, we can read it. There are not many lines. I did try to reduce it as much as I could, of 50 pages of my master thesis into just few lines. Okay, let's go through it. Raising of the sinus floor without any graft material is also considered as a strong alternative to the sinus grafting. No long-term availability of data has been reported so far, for especially with the bilateral sinus lift in the same patient with and without grafting. So my master thesis, it's a clinical trial. Obviously, the main issue was it was a bilateral sinus lift case, so it has to be done in the same patient. And it was really difficult to find one patient with both ends without any teeth or tooth. So it took me at least 1.5 years to find those patients, another half year to get the ethical approval. And then once my colleagues were graduating, I was actually doing my patients. So this is study done to a certain relative efficiency of sinus floor augmentation with allogenic bone and without any bone graft material. Hypothesis. It is hypothesized that in a single stage implant surgery where implants are placed simultaneously with lateral window sinus lift procedures, along with bone grafting material, the resultant bone formation is much higher than the one without any grafting material. This was my hypothesis. Although we know that grafting material only acts as scaffold for the incoming blood to form a stable clot around the implants and wouldn't act much in long-term stability of implant. However, if the grafting materials are not being used and Schneiderian membrane can be lifted up with the help of implants above the residual bone, even then the blood will fill up the space and form a clot, as Dr. Palti said just now. But will that clot be the bone graft can form the stable bone till the apex of the implant? That was my hypothesis. Material and methods. Obviously, because of the constraint of my master thesis, my study was only for 2 years. So we could only find 5 patients. They all were with some missing teeth or tooth. We had to do bilateral sinus lifts. Total number of 10 sinuses were treated. Control side grafted using allograft with simultaneous implant placement. Test sites without any graft with simultaneous implant placement. SL active implants were used because it was our understanding that they have more hydrophilic surface, so maybe we can get some advantage, although that was not the main plan, but we had those implants being used. Implant raised the Schneiderian membrane in the non-grafting side. Radiographic evaluation were performed to compare the gain in the vertical height of the bone in both the sinuses pre-op and post-op 6 months. As I told you, by getting the ethical approval and the patient, I already crossed my limits. So I could only get the post-operative results of 6 months, but now I'm following those cases for a year or so, and so far they are performing well. Inclusive criteria: patient with bilateral completely or partially edentulous posterior maxilla in need of dental implants, patient with residual alveolar bone height of less than or equal to 5 millimeters, patient with controlled systemic medical conditions, patient with average to good oral hygiene, no bleeding on probing, that's the least we could do, patient with the age of 18 years and above. Exclusive criteria: patient with missing posterior teeth only one side of the maxilla, we had to exclude them because we had to do bilaterals. Patient with the residual bone height of more than 6 millimeter, because this is an indication for closed sinus lift, and we had a plan to do open sinus lift. Patient with maxillary sinus infection, inflammation, or any other pathology. Patient with very poor oral hygiene, generalized plaque deposit, and bleeding gums. Patient undergone chemo and radio. Patient undergone for IV bisphosphonates. These are general exclusion criteria. Ethical approval was obtained by the scientific committee of Buckeye Medical University. Names and personal details of the patient were kept confidential. This is the preoperative of my first patient. This is a little eye test, but I can read it. This bone is 3.85 millimeter. This is 2.7 millimeter. Yes, there is a little bias in selecting the sites that wish to go for with graft, wish to go for without graft. My personal preference was, if I had the choice, where there more implants are needed, I went for that side without graft. So that's a personal bias. Second patient. So this is 3.3 and 2.7 millimeters. This is a small root that's lying there. And on this side, it's a 5 millimeter. I chose that side as a graft-free procedure. Once again, 5.24 and 3.2 and 5.24 and 5.2. And this is last but not, this is the recent patient we inducted. He had the residual bone height of 3 millimeters. My results. Okay, because I knew I would not get much time, so I have added a video of the whole procedure so you can actually see what we did. Let's discuss the results. These are the variables. Age, minimum was 50, maximum was 66. Mean was 60 with a standard deviation 7.32. We kept the length of the implant constant, that is 10 millimeters for all of them. Diameters were constant as well, that's 4 millimeter. Bone height test sites pre-operatively, minimum was 3, maximum was 5.2, and then mean was 4.3. We had a standard deviation of 1.08. Bone height test sites after 6 months, this was 7.5 minimum, 9.0 maximum, 4.07 mean, and with the standard deviation of 1.37. Bone height control site pre-operative, that's 2.2, and maximum 5.5, with mean of 4.47 and standard deviation of 1.53. Bone height control site after 6 months, 10, 11, 10.25 mean with standard deviation of 0.5. Resultant bone gain control site was 4.5, minimum, maximum 7.80, mean was 5.7 with a standard deviation of 1.45. We did this pair t-test to get the p-value, and it says the test sites, the baseline was, the mean were 4.3, standard deviation was 1.0893, after 6 months 8.37 with a standard deviation of 0.629, and it was statistically significant. Control site baseline 4.47, 6 months 10.25 with a standard deviation of 0.5. It's once again statistically significant. Discussion. There is limited evidence which is not enough to determine whether sinus lift procedure in bone with residual bone height 4 to 9 millimeters are more or less effective than placing a shorter implant or reducing prosthesis, like we do it all on 4. Sinus lift procedure has more complication at site treated. In several trials, different sinus lift procedures are compared and none is indicated to be better in reducing implant failure compared to other. In light of this, less invasive grafting technique should be considered, especially for molar areas. The use of osteoconductive mineralized graft doesn't seem to improve bone healing, but preserve the ridge volume for better implant restoration in future. Moreover, invasive procedures are less frequently needed. To have appropriate result, proper time for bone healing prior to implant placement is strongly recommended. This study highlighted the regeneration of bone growth after maxillary teeth extraction. This study highlighted that due to the rich blood supply of maxillary synods, its morphology predictable bone growth can be expected without putting any graft in the sinus cavity. There was not even a single study found done on split mouth design. This is prospective study of its own kind on human subjects with similar physiological conditions for both test and control site. The shortcoming of this study is limited sample size, individual expertise in performing the procedures, and measuring bias is noting the length of the bone graft after follow-up. Other studies with a greater number of patients should be done in this field with 3D scans to further demonstrate the complication and long-term outcome of alveolar regeneration technique. This is one of the case. I don't want to spend much time, but this side we did the graft. This side you can see the implants showing through. This is without graft. This is a video, little musical. I need, yeah, Mike, can I? How many of you knew Airwolf? Nobody knows? Airwolf? Okay. Can I? Okay. The dentist was doing it. Imagine me and dentist doing a movie, so can understand the technical issues. remember this is 3.25 millimeters of bone. But we still got primary stability. This is a stopper drill to be extra cautious. I normally place with implant with the machine, but with a very low speed, like 5 or maybe 10, nothing more than that. See the lift here. I just placed the membrane to just cover the window. This is a periacryl, it's a cyanoacrylate. I normally cover the wound most of the time with this. This is the bone gain. Obviously the picture which I'll show you just now, that's after crown in 6 months. This is post-operative after 6 months. This is actually the bone gain. Yes, there theoretically or clinically you can see a little bit more, which we obviously discuss in results as well. But this is hardcore bone too. Yes, there is no bone at the apex. Maybe with 3D scans, we can actually find out maybe there is a little bit of bone at the apex as well. But yes, by seeing just OPG, you cannot comment on that. Conclusion. This study concludes that residual maxillary bone height has increased radiographically in both grafted and non-grafted sites. The grafted sites, however, had early rise in bone height, which was caught up by non-grafted sites in few months. This non-grafted sites growth was due to tenting effect of Schneiderian membrane, and the volume was little less than the grafted sites found radiographically. Thank you for listening. I told you.
Well, thank you very much for presenting your master thesis with these two approaches in one case, in one patient. Is there any question about that? I open the, yeah, here. Wait some minutes, as long as you get the microphone.
Excuse me, did you try to use the lateral bone as a cap for the implant? Can you understand?
As the floor of the implant.
Yes.
Yeah,
yes.
that's one of the technique, but during my master thesis, I put this technique there.
Without this?
Yeah, without this. But
Maybe
that can be used, yes.
Maybe if you use it, you can...
Definitely we can achieve till the apex. Because with that you can use piezo. You actually make these osteotomies and make it like that. Yeah, I do it now. But in my master thesis, I just, basically in material method, I put this technique. But I do that as well. That's better than this.
Ah, yes, it's better.
That's better than this. And this case was, I think, 3 years old. So now there are a lot of things which I have changed in my practice.
So I expected Gustavo, the professional on sinus flow elevation.
I know his question.
Don't you think that the outcome of the sites in which you didn't put any graft material could be improved by using PRF membrane?
Yeah,
Because
that's a very good question actually. BIOS, as I think Dr. Palti well said, BIOS still, it's a xenograft. And with the long-term studies, it shows that yes, it can shown in X-ray, it's a bulk, but it's not a bone. It's plastic still, even after 18 years, 20 years.
No, but I'm not talking, I'm talking about PRF membrane.
Yeah, definitely. Okay. PRF membrane is still not been proved to work on bone modification or bone formation. It's very good for soft tissue healing. Still, there have been studies going on. They are trying to find out.
But definitely will stabilize more the blood clot on top of the tip of the implant if your goal is not to place
okay,
any
let's
graft
put it this
material.
way. What is the life of that that PRF membrane?
Sorry?
How much time does it stays inside?
Yes, but will stabilize.
No, just answer my question. What is the life of that clot?
7 to 12 days.
7 to 8 days, right?
Yes.
There is no bone cascade that start in 7 to 10 days. So maybe it can help if your Schneiderian membrane is ruptured. Then you can put it there along with other membranes so that it can heal your Schneiderian membrane. Otherwise, normally placing it, yeah, maybe it can give you some good feeling that I'm putting something in. But trust me, it has no role so far. Maybe we'll be coming next time in innovation jumps and they'll be discussing this thing that yes, it has some role, but till now there is no role of bone formation of this PRF membrane.
Okay, I think there are two experts here. We have two more questions, then we have to close because we are over time and we have also
Adi,
some
do you have a
handing
question?
over of certificates.
Yes. I had a feeling that Chukrun was the teacher at this master group, no? Joseph Chukrun?
Not.
No? Well, I just want to put you on the right track, both of you. There are proof cases since 2006 that PRF creates bone. Definitely. It's not like a research project, 12 years, bone, first. But this is not the reason of my question. You took so many precautions, you did a beautiful job, but you have a drill stop and you have so many stops in your system that I appreciate your caution. But everybody in the room never do it like this. Because I do sinus elevation since 40 years. I learned it from Hill Tatum. And I took out of the sinus thousands of implants in my career from other doctors. If you do this technique, which is not bad, use a bigger cover screw for your implant so it doesn't go into the sinus. This is my tip for you for free. You go home, never do it like this because when you make the last turn with a cover screw, the implant goes in.
Yeah.
And you are in trouble. So use bigger cover screw every time you do it. Because you are so cautious in everything,
Agreed.
but you put a small cover screw. So this is the only thing. But PRF works, and PRF is proven to create bone, not only soft tissue. So. Shukrun will get a heart attack if you tell him. Tell him that.
Yeah, or maybe polish for
So please.
So regarding
with a wide diameter.
regarding the PRF, one of our students in MOI 15 is doing this study.
Sorry?
Mona, she's done the study on PRF sinus floor elevation.
Okay.
No PRF and versus PRF.
With PRF, without PRF.
PRF and without PRF. So I
Okay.
just thought it'd be interesting to talk to her tonight.
She's not here?
So here, the next one. Give him the microphone, please.
Well, I'll ask later.
Oh.
Sorry.
I had the question.
You don't put nothing, you said, but sometimes you can find that the coagulum is not stable. Sometimes you can see also there's an adherent membrane that goes really down, very near the implant. So the quantity of bone that you could have is very small. So the reason you put something to have to stabilize the situation is that because you could gain more bone. We are not talking how much bone.
Basically,
but,
you gain more space. You
gain
more space.
Because
Yes,
this
they
is the
work as a
problem.
space maintainer.
And
Agreed.
if you don't put nothing, you have only coagulum. That maybe sometimes you could be in a situation that you will not have so much bone, and the implant is not so much stable.
Yeah, perhaps this is a reason because you see in the video very nicely that the membrane is floating during the breathe. And I think in the tip, perhaps this makes reason that the blood clot is not stable, but 1 millimeter or 2 millimeter behind the tip is stable around the implant, and then it's creating the bone. This is guessing, I don't know, but this is what you say. There's a risk that especially on the tip and the apex of the implant, it cannot have a stable blood clot due to the membrane floating. Yeah.
And especially this happen if you place one implant, maybe a single implant. So obviously, if it doesn't have natural tooth either ways, yes, it goes like that. You're absolutely right. You're absolutely right. The one which yeah. I do it with the piezo. Yeah, it works very well. Yeah, that's what I just answered.
This we already discussed.
Yeah,
this we already discussed.
Yes.
Okay.
I do it.
So the last question, because I have to close now. Dean,
Just
you
really
get the last
quickly,
one.
in any of your cases, did you have any sinus membrane perforation?
Unfortunately, no.
Unfortunately, okay. I was just wondering if that's part of your exclusion criteria, because it wasn't in there.
Sorry?
It wasn't as part of your exclusion criteria if you had a sinus
because
perforation.
we know if we have a sinus membrane perforation, we can repair with the membrane.
And you don't think that's going to have any effect on the outcome?
That's what I'm saying. The sample size was so small. There were just 10 sinuses, 5 patients.
So
I was lucky enough. So otherwise, I had few perforations, not in this study when I was doing the sinus membrane, but I repaired it then and there by putting the membrane there and place the. Then this membrane acts as a tent, and I place the implant, grab that area, and close up and come again.
Okay. So you see a
So
lot
that's
of
not the
open
exclusion
questions. So I have to handle over you the certificate
Thank you.
that you make this big job. Thank you for coming from Pakistan.
Thank you very much. Okay.
I'm really impressed that so many people are staying here. Even we have 40 minutes more. And before I close this Congress, I have to say thank you very much. You see how much engagement our two IT persons, Fabian Möller and Safi Shankun. Please give them some hands that is everything fine. And of course, the staffs who work around before and today, and tomorrow it's going on. But the lead of this is Vanina Jakel. Please give her also. And last but not least, before we go, we want to hand over some certificates from the ISOI to take some photos, and we need your hands to clap, please.